Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks to Brian for inviting me. I'm really excited to be here with you all. As Hillary mentioned, that my clinical practice is really in lung cancer screening and pulmonary care in general, but my research has always included people with HIV, and that's a particular population that I really care about. And I started my whole medical journey doing outreach and testing for HIV way back in North Carolina, probably about 15 years ago, 20 years ago. So really excited to be here talking about lung cancer and really practical strategies to think about it and the increased risk in people with HIV. So I'm going to leave this up for just a second, but this is just the broad disclaimer from AETC. And then I have no disclosures related to this talk. So my objective, knowing that you all are clinicians taking care of people with HIV, are to define both the risk and risk factors for lung cancer in people with HIV, to describe approaches to both primary and secondary prevention of lung cancer in people with HIV, and then to understand approaches to tailor smoking cessation being kind of primary prevention, and then lung cancer screening being a method of secondary prevention for a population of people with HIV. So I think the first thing to talk about is kind of the epidemiology of lung cancer in the general population and in people with HIV. So this is some data from 2022, and this is from the SEER registry, so a good approximation of the cancer cases and deaths across the United States in 2022. And it's arranged by the incidence of cancer. So what you can see on the left column here is that lung cancer is the third leading cause of cancer. Then if you look here at the cause of cancer deaths, unfortunately, it dwarfs all the other causes of cancer death. And really, if you take all the kind of screen detectable causes of cancer, lung cancer is higher than all the others combined. So I would, it's a fair statement to say lung cancer is far and away the leading cause of cancer death in the US. In terms of its impact in people with HIV, I'm going to show you kind of some data around all these points. But I think it's important to know that lung cancer is the most common cause of non-AIDS defining cancer, that as there has been an epidemiologic shift and thankfully increased life expectancy for people with HIV, it's the leading cause of all-cause cancer death. It's a leading cause of death, as it rivals things like cardiovascular disease, strokes, and other things in certain populations of people with HIV. And that unlike the general population, where despite those high numbers, that cumulative incidence of lung cancer has actually been declining, in the specific population of people with HIV, with improved HIV management, we've actually seen cumulative incidence increase for lung cancer. And that's largely a product of increasing ages. So if we look at the increased risk of all cancer types in people with HIV, this is data from a really great study that I had the opportunity to work on during my fellowship. A lot of great data coming out of the NCI from Eric Engel's group. In this case, it's his HIV cancer match study, which matches data from 9 states and territories. And in this case was data ranging from 1996 to 2012. And so it included almost 500,000 people with HIV, and then standardizes these incidence rates. So what we call SIRs, or standardized incidence rates, based on the US population, which is standardized by sex, age, race, and ethnicity, calendar year, and then the registry area. So you get a good estimate of how the incidence rate of cancer compares between people with HIV and people without HIV. And so for all cancers, including AIDS and non-AIDS defining cancers, you can see that here it's about a 1.7-fold risk. And as you would expect in things that are considered AIDS-defining cancers, which are often pretty rare in the general population, that SIR is really high. But if you look at things that are described as kind of non-AIDS-defining cancers, not related to HIV and often not related to infectious disease or viral causes, that incidence rate is still high. If you take away the virus component of it, you're getting down to a population that's pretty similar in terms of cancer incidence rate. But one exception to that is not virus related and is not an AIDS-defining cancer is lung cancer. And so what you can see here is, which is a little bit dissimilar to the other virus-unrelated non-AIDS-defining cancers, that we have a twofold increased risk for lung cancer. And this gets to what I mentioned about the incidence of lung cancer in people with HIV versus what's been happening over time in people without HIV. And so anytime anyone shows graphs like this and just talks about them, I'm always like, what are you doing? So I'll try to explain it. And so essentially the solid line here is the most recent era in this study. Again, the HIV cancer match study, 2005 to 2009. This wider dash is 2000 to 2004, and then the dotted line, 1996 to 1999. And what you can see is essentially the cumulative incidence is actually increasing in these cohorts. And what you see is that this is the most recent here, 2.3 in people without HIV. We're seeing this cumulative decline. So we're seeing kind of opposite trends. And that's probably largely explained by decreased smoking behavior in the general population, leading to this decline with the same age structure. And the age structure of people with HIV, thankfully, has changed a lot over this time period. So that's why we're seeing the increased cumulative incidence rate in people with HIV. So similar to the general population, the increased risk is really largely driven by smoking behavior. So in the wider population, about 85% of all cases of lung cancer are attributable to tobacco use. And so the increased risk of smoking in people with HIV is really driving a lot of the increased incidence of lung cancer. So among people with HIV in Western countries, it's hard to get a great estimate. It very much depends on a number of factors: patient intersectionality, geography, local context, all these things. But in different populations, it's somewhere between 35 and 50% of all people with HIV in Western countries currently smoke. And about 60% of these patients are at least former smokers. And that, if you look specifically at the US, there's some pretty good data that suggests that's a twofold increase risk factor for these patients. 40% of people with HIV currently smoke in the US versus 20% of adults without HIV. Both those numbers are declining, but there's currently, quite a disparity. Now, there is some really interesting data that I could give a whole talk on, and it's not very strong, but it would suggest that HIV is an independent risk factor for lung cancer, and that is really independent of its effect on traditional markers of immunosuppression. So it's not highly related to viral load, load nadir, or CD4 nadir, current CD4 count. And probably one of the best studies for this, which again, I wouldn't call it strong data, but it came out in 2012. And basically they looked in a very large population of veterans and tried to build a multivariable model where they really could look at kind of attributable risk to these various risk factors known to be associated with lung cancer. And so they were able to adjust for age, sex, race, ethnicity, smoking exposure, COPD, and bacterial pneumonia. The one limitation, because it was very big data, was they couldn't do a really comprehensive granular adjustment for smoking duration and intensity, what we sometimes call pack years. How many pack years has somebody smoked? But they did have strata of smoking status. And what they found was that this relationship persisted across strata of smoking status. So what we see is, independent of all those things, that HIV infection is related to a 1.7-fold increased risk of lung cancer. And it really remains unclear what are the risk factors. Are they solely traditional ones, even though, as I told you, that I could talk about it, but that data's been mixed around CD4 nadir, CD4 CD8, a lot of those things. Is it bacterial pneumonia? Is it related to alternative markers of immunosuppression? Is it related to ongoing immune dysregulation despite reconstituted immune systems? I think that really needs to be unpacked. So this is mostly a practical talk. So in terms of primary prevention, I think the one takeaway from this talk is to really work with patients on smoking cessation. And I've done some work and studies in Madison Clinic here, and there's a laundry list of things that you all are accomplishing with your patients at each visit. And if I could just move smoking cessation a little bit up that list, that would make me really happy. And I'll try to show you some data to support that. So this is a nationwide cohort study of people with HIV and matched uninfected controls from Denmark. So in this large population-based data, they looked at life expectancies of in various situations, and all other things being equal, a 35-year-old person with HIV who was a current smoker had a life expectancy at the time of this study of 62.5 years. The life expectancy of that same person, if they were never a smoker, at that point is approaching that of a person without HIV who's a never smoker. So what you can see is that there's a substantial difference in this attributable mortality to smoking. I really love this study because the prior study doesn't tell you much about what to do with all of our folks that are smoking right now. What impact can cessation make on their lives? And so this is a really nice study from a friend of mine, Krishna Reddy, out of MGH. He published in 2017, building on the best available data to build this Monte Carlo micro simulation that looks at different potential outcomes through a lot of different sensitivity analyses to take the epidemiologic data and try to understand what impact smoke exposure has on cumulative lung cancer mortality at this point by the age of 80. And so it's a very similar relationship in women with HIV, but there's not a combined graph. So I've pulled the men with HIV here. But what you can see is it's kind of modeling the cumulative lung cancer mortality percent by the age of 80 here on the y-axis, and on the left, what happens over time. And current smokers have nearly a 30% chance of getting lung cancer at some time in their life if they continue to live until the age of 80. And these are all the current smoking curves, depending on whether they're classified as heavy, moderate, or light. The former smokers implies that people quit smoking at 40. So that's the beginning of this graph. So that's a totally doable thing, and is the age at which we're talking to a lot of our patients. Like, yes, they have a substantial smoking history up to that point, but what impacts can you make by quitting now? And what you can see is, a marked difference in cumulative incidence of lung cancer. And then here are the never smokers. But this is a massive difference that we can take to our patients who are currently smoking. In terms of the impact of smoking on people with HIV, the broader impacts, which, I always like to think about what lung cancer is kind of my general focus, but there's so many benefits to smoking cessation. So people with HIV who smoke are 6 to 13 times more likely to die from lung cancer than an AIDS-related cause. That's kind of the lung cancer bent. Quitting by age of 40 can result in drastic reduction in lung cancer mortality. So again, like I said, a 40-year-old heavily smoking man who continues to smoke can expect to have a 29% cumulative lung cancer mortality by age of 80, and that drops to 8% if he's able to quit at 40. And I really like the conclusion that projects us out to what's doable, because our current cessation methods can, if followed, generally result in a 20% cessation rate in kind of the trial setting. So if we were able to employ those cessation techniques, and 20% of current smokers quit, that'd be 6,900 deaths prevented, or 12% of the total lung cancer deaths in the United States among people with HIV. So in terms of cessation, a common question I get, because I also run our tobacco cessation programming at Fred Hutch, is are these things safe in a variety of settings? And the standard approach, kind of the gold standard of smoking cessation, is going to be nicotine replacement therapy, both long-acting and short-acting, and then potentially a medication. And I would heavily advocate for varenicline over other options. So both standard pharmacologic therapy and NRT are safe and effective in people with HIV. There have been phase 3 trials of varenicline in people with HIV in the US and France. There's limited studies of interventions that are tailored to people with HIV in terms of smoking cessation. There is some evidence directly from people with HIV that there's an improved efficacy of intensive interventions. There's improved efficacy of combining behavioral support and pharmacotherapy, and lots of data to suggest that patient motivation may be the key factor. But I would say that that doesn't mean that it doesn't change. So in a lot of the studies of smoking cessation, including the ones that we have done, patient motivation is something that needs to be revisited and reassessed multiple times. There's increased interest in vaping as a harm reduction strategy. That's obviously done and employed pretty heavily in the UK. And we don't get into that business here, and that's another talk, but I'm happy to talk about it at some point. And then really consider your patient's unique identities, circumstances, and motivations. And that's something we hear from patients, and I think results in success rates. In terms of secondary prevention, lung cancer screening, won't spend a lot of time on this, but the evidence of lung cancer screening in the U.S. largely comes from the National Lung Screening Trial, published in New England Journal in 2011, that showed this 20% reduction in lung cancer mortality with a low-dose chest CT performed annually for 3 events compared to a chest x-ray. And then there was also a reduction in all-cause mortality, just showing you how much lung cancer contributes to all-cause mortality. It is not without problems. There's a high percent positive. 96% of these are going to be false positives, so that's always something to think about. And so lung cancer screening is not, we have no qualms about the fact that it's not always the simplest modality, and it certainly requires a lot of follow-up and specialized resources sometimes to be able to do. How do we think about it in people with HIV, few of which have been included in any trial of lung cancer screening? Well, there's some things that might tip the scale to say lung cancer screening may be even more beneficial in people with HIV. There's an increased incidence of lung cancer, there's younger age of diagnosis, there's increased tobacco use in this population, and maybe lung cancer screening is a teachable moment. There are some potential downsides, some of which have been investigated and proven not to be so concerning, and some of which are concerning. So one that I think is true is that patients in this age range who have a substantial smoking history and are 50 to 80, which is our age range for lung cancer screening, people with HIV do have more competing risk of death than other populations, and that has been shown. So that has to be considered in terms of thinking through a harm and benefit approach to lung cancer screening. 2 things that were concerns that don't seem to really be substantiated is that there's going to be an increase in false positives in people with HIV, with the idea that folks have other lung diseases, infection, or that there's increased diagnostic or therapeutic harms in this population. So these are our screening trials in people with HIV. I won't dwell on them except to tell you that NLST was 50,000 participants. These are pilot trials of 200, 400 people. So the only, trials were really done to show that this, could be done and to give people some implementation examples of it being done. But in no way can they really show efficacy for lung cancer screening. So I just have those up there in case people are wondering, have those been done? We did a nice study looking at this idea of false positives in people with HIV because it was an initial concern after the initial recommendations came out in 2013. And this was a sub-study called VAX from the VA looking at 158 people with HIV and 133 people without HIV who met criteria for lung cancer screening and had a chest CT that we could look at in detail. And we had a lot of clinical information on these folks. And what we found was really a similar portion of non-calcified nodules, which are really the thing that is scary as terms of a false positive, in people with HIV and people without HIV, almost exactly the same. What we found was it was a predictor of having more nodules was this group of patients who had a CD4 count less than 200. And so it's, again, this idea that it is not surprising that probably cancer screening, lung cancer screening is not a priority and may result in harms in these patients with a low CD4 count. We've also done a study in the kind of larger cohort of VAX, which is 44,000 people with HIV and 88,000 controls, where we looked at what happens after standard procedures that are done as part of a diagnostic pathway for lung cancer screening. Again, it's kind of a surrogate for the harms. And what you can see here is these are bronchoscopic type biopsies, and these are transthoracic, so it's either inside out or outside in. And in general, the summary of this slide for me is that there's really not much difference in terms of the common complications, which would be need for chest tube placement, bleeding, pneumothorax, or hospitalization between people with HIV and kind of matched controls. So in order to really think through how should we do lung cancer screening for people with HIV and should it be different than the general population, I was part of a study where we looked at building models in the exact same way that the USPSTF does to inform their criteria. So there is this model called the Lung Cancer Policy Model, which has now been continuously updated to inform 2 cycles, 2013 and 2021, of the USPSTF recommendations for lung cancer for the general population. And then we applied that same strategy using the best evidence for people with HIV. So again, it's a Monte Carlo micro simulation thinking through kind of a decision analysis method on all the possible outcomes if you use different screening strategies. And the included information was from that larger VAX cohort that I talked about, SEER data, Kaiser Permanente, Northern California HIV cohort. And we looked at 12 combinations of screening criteria where we vary the age of initiation. At the time this was done, the age was 55 for the USPSTF. It's now 50. The age of termination at the time was 77, is now 80. So we didn't look that far. And then smoking pack years, which 20 is the recommendation now, 30 was the recommendation then. So these things have changed based on the global Monte Carlo microsimulation model. So importantly, we excluded people who were non-ART adherent and people with CD4 count less than 500. So these strategies don't apply to those patients. And essentially, this is called the efficiency curve. Things that land on this strategy balance best mortality reduction and harms. And harms are surrogate, or screening, number of screening CTs ultimately ends up being a surrogate for harms. More screening CT, more potential for harm. And this, what was the criteria at the time, 55 to 77 and 30 pack years, landed on this efficiency curve, but so did other strategies, including this strategy that we use now. The reason why this strategy is nice to highlight is it had a relative lung cancer mortality of 20% among those screened, or 19%, and that's very comparable to the 20% for NLST. So it helps us figure out that the guidelines probably work just as well, not exceedingly better, not exceedingly worse for people with HIV than people without HIV, because we're not going to be able to, unfortunately, do a large-scale clinical or randomized clinical trial of lung cancer screening in people with HIV powered to the kind of patient-centered outcomes we'd like to see. So we have to rely on stuff like that. So in terms of take-homes for you all, people with HIV are, I use the term covered, meaning that if you have Medicare, Medicaid, any form of private insurance as of right now, and this may change, currently covered at no cost sharing to the patient. And that's because it's a USPSTF grade B recommendation. And for people with Medicare, it is a CMS guideline supported recommendation. And so those criteria are the same for people with HIV as a general population. So age 50 to 80, it's a 77 cutoff for CMS. 20 plus pack years of cigarette use, which again is asking the patient over the time that you smoked, what's the average number of cigarettes you smoked a day? And then that kind of becomes a pack year. So a pack a day is 1 pack year. And then do they currently smoke or have they quit within the last 15 years? My advice would be to really strongly consider HIV control, competing risk of mortality, and patient preferences in decision-making. And so we partnered with Madison Clinic and piloted, we actually kind of used a user-centered design approach to build a shared decision-making tool and modify an existing one for people with HIV, and then pilot it to kind of work through these issues of competing risks for mortality, benefits and harms, and personalized preferences. And then the important thing is that CMS mandates and other services recommend that you do this shared decision-making encounter and you formalize it as part of a lung cancer screening process. So what that means is that before someone has their first lung cancer screening CT, you actually do sit down and you talk to them. You try to personalize a discussion about the benefits and harms of screening. That includes thinking about screening in context of overall medical care and goals. And that also does include the smoking cessation piece, including working towards cessation for folks that are continuing to smoke. We know stigma is key for those patients, so trying to do it in the most stigma-free, supportive way that you can. And then encouraging, emphasizing, congratulating on abstinence from smoking among people that used to smoke. So in conclusion, lung cancer is a substantial cause of morbidity and mortality in people with HIV. Among people with HIV currently smoking, successful cessation, hard to say, can vastly expand life expectancy. Traditional methods of cessation are safe and effective in people with HIV. Lung cancer screening is an effective tool for lung cancer-specific mortality reduction. And I didn't show this data, but in the general population, it has an additive benefit to smoking cessation, so it's not an either or. The main harm to consider in people with HIV, I think, is competing risk. The initial other concerns might be a bit overblown, and we really do need more tailored approaches, so need to design and evaluate implementation studies to support tailored methods for cessation and screening in people with HIV. And so that's just me plugging the importance of doing work like I want to do. So please tell other people to fund such work. So yeah, here's the general acknowledgement, and then I'm happy to end my show and then answer any questions.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.